I am a pulmonologist working in Kolkata. I'm also one of the directors of APACI. And a big thank you for arranging this to Marianne and Anastasia. What I'm going to talk today about is to take you through vaccine overview. You'll have detailed sessions about each individual disease processes and about vaccines as we go through today. So what I aim to do over the next 20 odd minutes is to speak to you about the concept of adult vaccination and what, in my view, are challenges, especially perceived in India and other developing countries, and maybe a way forward in how we could do things differently. So that's what I'm going to discuss over the next 20 odd minutes. I'm going to talk about a little bit about the burden of vaccine preventable diseases. I'll discuss adult vaccination as a part of patient management plans. I'll try and discuss what challenges we have faced in instituting adult vaccination programs at a hospital level. We'll discuss a little bit about advocacy, building, and policy shaping for adult vaccination. And hopefully at the end of all that, I'll have some key take-home messages for all of you. So vaccines have been around in the adult space since 1978. And as you all know, vaccines are there to stimulate your immune system, and they do not give you the disease it's designed to prevent. I've put up this slide, which I'm sure most speakers will show you through the course of the day. I'm not going to take you through all of this. However, suffice to say that the various vaccines that we're going to talk about today are in the space of influenza. We'll talk a little bit about the Tdap vaccine, the tetanus, diphtheria, and pertussis vaccine. We'll talk a little bit about the zoster recombinant vaccine, pneumococcal vaccine, and we'll talk about age groups, at-risk groups at which these vaccines need to be administered. So whenever we speak about this vaccine, and I'll come back to this in the course of this talk, we'll talk about it in the course of pregnancy, we'll talk about it in the course of immunocompromise, and about comorbid diseases where these vaccines need to be given irrespective of age. So we'll start off by talking about the burden of vaccine-preventable diseases in the adult space. Now, when you look at leading causes of death across the globe, WHO estimates in 2019 say that 7 out of 10 deaths are due to non-communicable diseases. And thus, that must be because there's a lot of work that's been done in the communicable disease space, in the way of prevention, in the way of treatment, which has made NCD the largest killer as far as various global diseases are concerned. So of all the non-communicable diseases together, they accounted for 74% of deaths across the globe in 2019. I want you to look at this little slide. I'm not sure whether this projects well. The ones with green circles on them are the ones with communicable disease. So you have lower respiratory tract infections, you have neonatal conditions, and you've got diarrheal diseases which are in the space of communicable diseases. All of the remaining are in the space of NCD. So if you look at the top 10 causes of death globally, 80% are due to non-communicable diseases. 44% of the total number of deaths worldwide are due to non-communicable diseases. So the roles of vaccine based on that are in 4 different spaces, which I've outlined for you there. Vaccines prevent 2.5 million deaths per year, and they save 5 deaths per minute based on WHO survey with reports from 2019. Vaccines treat both communicable diseases, but in the recent space also non-communicable diseases like cancers. The life expectancy has increased from 58.5 years to 70 years in the space of about 40 years between 1970 and 2010. And vaccines have reduced the total deaths from communicable diseases from 33% in 1990 to 25% in 2010. So 4 different spaces: the fact that they prevent deaths, 1 out of 5, the fact that they treat communicable diseases, but also in the space of NCD today, the fact that life expectancy has changed significantly and the total number of deaths have been reduced are what makes vaccines so very important. So the question we are asking is, why this emphasis on adult vaccination? And I'll give you a little bit of data from India. And I want to highlight 2 different points from the overall prevalence of vaccine-preventable diseases in India. These are some of the facts that have been published in the last 10 years in the space of vaccine-preventable diseases in India. And you can see 5 different diseases outlined. The list could have been much longer. I have picked these 5 because there's data in the space of these 5 different diseases. However, you can see, I won't read you through this data, but you can see that the data is sketchy. The number of reported cases is small, and that's the challenge that we face when we talk about vaccine-preventable diseases, especially in developing countries like India and others, a lot of whom would be in this room today. The best data we have is in the space of influenza and pneumococcal diseases. And this slide in small print, again, I don't want you to read through it, but it talks about outbreaks that has predominantly affected an Indian population over the last 15 odd years. I want you to focus on certain areas on this particular slide. You can see time spaces for outbreaks between 2005 and 2017. You see various vaccine-preventable diseases that are outlined on this slide, which starts off with meningococcal disease, hepatitis B, of course, influenza, pneumococcal diseases, diphtheria, etc. And then look at the setting. So they start off with small villages in the outskirts of big cities, and then you have tertiary care hospitals, and you have various corners of India, a population of about 145 crores. You have tertiary care hospitals, you have community hospitals, university hospitals, and then you have states starting from the northern to the southern part of the country. And the outbreaks have influenced, they have caused disease in varying numbers of population. So the outbreaks are not limited to states, to small cities, to villages, but it encompasses the entire country. Adult vaccination, in my view, is important for 4 different reasons. The fact that age-related immunosenescence reduces resistance to infections across the population. The fact that chronic illnesses, like we just pointed out, increases the susceptibility to infections. There's changing epidemiology and emergence of diseases. We looked at COVID, which emerged and hopefully is on the mend now, it's on the down. And then there's the reemergence of diseases like tuberculosis, malaria, about which we'll have discussions hopefully through the course of the day. And then there's inability of childhood vaccinations to offer long-term benefits in individuals. When we talk about adult vaccination cohorts, we talk about the benefits of adult vaccination in 2 different categories. We talk about it in the space of high-risk individuals, and we talk about it in the space of antimicrobial resistance. So when you look at high-risk individuals, the risk could be related to the age of the individual, above 65, or in Indian populations where immunosenescence seems to come early, above the age of 50. You talk about it in the perspective of pregnant women, about workers who are at higher risk, for instance, healthcare workers, and then various comorbid diseases that are outlined on this slide in front of you. And you will hear through the course of today. So people with chronic lung disease like emphysema, chronic heart disease, diabetes, people with arrhythmias, the list is long. And then you've got at-risk individuals, people who work in labs, people who work as nurses in ICUs, etc. So that's the at-risk individuals. So high-risk individuals on one side, people who are on risk due to the professions that they entail, and then the AMR challenge, where vaccination can reduce the rate of multi-drug resistance by reducing the prescription of antibiotics on a long-term basis. Vaccines also may be helpful to target drug-resistant variants of pathogen and hence again reduce the number of prescriptions of antibiotics and reduce AMR in this population of patients. When we talk about comorbidities and life course of immunization, in comorbidities, we have talked about various vaccine-preventable diseases which needs to be addressed, especially in the high-risk population of patients. When we talk about life course immunization, and again, you will hear this as a strain that goes through the course of this meeting today, it focuses on extension of vaccination from birth, goes on to childhood, adolescence, adulthood, and in older age groups. The benefits of vaccination can be divided into 3 different sections. The one we have talked about already in this perspective of health. So in the eradication of infectious diseases, reducing infectious disease morbidity and mortality, inducing herd immunity, preventing antibiotic resistance, those are the benefits that you envisage in the perspective of health. Then you have the economic benefits with cost saving, productivity gains, reduction of loss of school days or work days, and so on. And then you have the last bit, which talks about benefits in the social perspective. So equity of healthcare, empowerment of women, impact on life expectancy and opportunity are different areas in the social perspective. So when we have talks today in individual disease processes, those are the three bits that we need to think about. Benefits of vaccination in the way of health, in the way of economics, and in the way of social welfare. So how do you integrate adult vaccination as a part of a patient management plan, and how do you decide who to vaccinate? We've discussed this already. Think of it in two different headings. Think about it in the perspective of risk groups and those others who are recommended for vaccination. So we have said about risk groups. Risk groups are in 4 different strata. The older age group, which might be above the age of 65 or above the age of 50, depending on the disease and the part of the geography that you're talking about. People with chronic medical conditions is second. People with immunocompromise is third. And pregnant women is the 4th category you think about when you think about at-risk groups. What about the other groups recommended for vaccination? We said healthcare workers and other occupational groups at risk would be the health occupation group. And then you have other occupational groups, essential services, first responder groups, a lot of which you saw during COVID, military groups, airline pilots, etc., the veterinarians, poultry workers, and so on would all be within the occupational groups who need to be vaccinated as a matter of priority. When you think about taking a prior vaccination history, those are 3 categories, 3 boxes that need to be ticked. Know what vaccines the adults have had in the past. Ask for a written personal record, which is often lacking in lots of developing countries in the adult space. So ask for written personal records of vaccination. Look for doctor's office or clinics where the vaccines would have been given in the past. So we'll talk a little bit about vaccination in older adults and the 4 challenges that we face in this space. So the reason for increased risk of disease is a decline in immunity. We spoke about immunosenescence. So a decline in immunity, in innate and adaptive immunity, and a lack of immune responses, what we termed as immunosenescence. There's multiple barriers. I have tried to simplify the barriers into 3 or 4 here, but there's multiple more barriers. Barriers in attitudes and beliefs regarding vaccination, a lack of conviction in us as doctors in recommending vaccines to the right population of patients, a lack of knowledge about the vaccines, and the perceived susceptibility of disease, or the thinking that people are not susceptible to disease when they actually are. So they are the broad headings about barriers, but there's lots more about barriers that we need to speak about, and we will do through the course of today. Then there's unmet needs. Unmet needs about vaccination against other leading causes of infection, trying to find vaccines which improve immunogenicity, and you will talk about adjuvants, etc. as we go through, and try and think of ways in which you can improve immunogenicity. Better consideration of immunity and risk of travel-associated disease is the other unmet need that we speak about. And then diseases which are targeted by vaccination, and you see the list on there. We spoke about it. So the influenza, the pneumonia, the shingles vaccine, the Tdap vaccine, the COVID vaccine. So that's the target vaccines in the space that we are speaking about. When we talk about vaccination in immunocompromised adults, we have talked about these reasons for vaccination already. When we talk about barriers, the fact that certain forms of immunocompromise, HIV for instance, changes the efficacy and safety of vaccines and the vulnerability of patients to diseases which are preventable by means of immunization. And here again, the diseases targeted by vaccination are more or less the same. You need to be more careful about live vaccines in the space of diseases that are targeted by vaccination. And hence you see some changes in diseases targeted by vaccination in case of immunocompromised adults. When you talk about vaccination in pregnancy, I think the vaccines that are recommended become smaller because the evidence in this space is far more lacking. The reasons for increased risk in this space is reasonably easy. It's intuitive. So altered immune status during pregnancy, the mother and the fetus both have immune responses which are different in this particular space. The barriers are, again, lack of doctor consciousness, lack of knowledge. People are hesitant about vaccination, especially during pregnancy, when maybe the vaccines are most needed. The unmet need is that vaccination against a lot of leading causes of disease during pregnancy, the data about safety is lacking during pregnancy. And the diseases targeted have put as 3: influenza, tetanus, and pertussis are the 3 vaccines that can safely be given in this particular space. In the last 5 to 7 minutes, I'll talk about driving a vaccination program at a hospital level and the challenges that we have faced. So these are recommendations from the National Vaccination Advisory Committee, and they have 4 recommendations in standardization of adult immunization practice. They've said you need to assess immunization status of all your patients at every clinical encounter. And I think this is very important, the fact that whenever you come across a patient where a vaccine is indicated, you need to assess, you need to ask, you need to ask the questions we mentioned a little while ago about their vaccination status. You need to strongly recommend vaccines that the patient needs, administer the needed vaccine, or refer them on to people who are capable of delivering these vaccines to individual. And you document the vaccines that have been received by your patients on a regular basis. The second part is assessment, which is critical first step in ensuring that your adult patient gets the vaccines that they need. And to take a call as to what vaccines they need, these are 5 different factors that need to be inquired about. So the age of the individual, the comorbid diseases, the health conditions that we spoke about, the lifestyle of the patient, the travel that they intend to do over a period of time, and the occupation. All of these define what are the vaccines that this individual is supposed to take. It's important to strongly recommend vaccines that a patient needs, but these are factors that need to be taken into account when you recommend these vaccines. So there should be a shared, tailored reason why that particular vaccine is the right vaccine for the individual. It's important for a healthcare worker to have the conviction to prescribe and convince the patient about the vaccine. So highlight the positive experiences with the vaccine, addresses the concerns that the patient might have, remind the patient that the vaccines protect them against a number of common and potentially serious disease processes, and explain the potential costs, the economic burden of the disease that this patient might entail if they got afflicted by this particular disorder. The administration of the needed vaccines is important for the individual, and like we said, if you work in a healthcare structure where you cannot administer the vaccine, it's important to refer the patient on to the vaccine provider. Most vaccination services are convenient if you stock it in your own clinic. The stocking we'll come to for a moment in a bit, but it needs to be stocked under the right circumstances, the right temperature, and so on. And for vaccines that you don't stock, you refer them on to the providers. You need to document what vaccines your patient has received in a vaccination card, which is essential for the next visit that the patient comes for or the next doctor that the patient goes to. These are factors that we wrote down, we tabulated in a publication about 2 years ago, creating opportunities for vaccine access. So AMS programs and wellness centers and annual health checks where the vaccination status of individuals needs to be checked, advising specific vaccines before major surgeries or procedures, improving vaccine coverage in remote areas with mobile vaccination vans, which have thankfully become more prevalent throughout our country, vaccinating patients at home by healthcare nurses, educating patients during routine consults, digital or written prescriptions or SMSs, which have become common, artificial intelligence integrated hospital information systems. These are coming into vogue in tertiary care centers, but not in secondary and primary care, and it needs to be cascaded downwards, and outpatient and inpatient records to question the vaccination status of individuals. So this is the cross-functional stakeholders at an adult vaccination program in a hospital. So patient education during a routine consult is one. Having counselors or consultants who talk about vaccines is second. Allied health professionals like lung function technicians, dialysis technicians, looping them in and using them for counseling about vaccination is something that you can do where healthcare resources are sparse. And then intensivists, people who are very sick, recovering and going out of hospital, looping in intensive care specialists in counseling patients and their relatives after the acute emergency is over is important. So adult vaccination is not well known in India still. Only about 6% of individuals are getting the vaccines that they deserve. And that's across the space and data from 2021. And hence, all healthcare physician personnel should compulsorily get vaccinated. If healthcare personnel get vaccinated, the conviction of vaccinating people becomes greater. And you have a safety net by not transferring disease onto other individuals. National vaccine societies like the Indian Chest Society should write up guidelines. So we did our guidance in 2019, and sensitization of government stakeholders and insurance companies about benefits of adult vaccination is what is lacking. Can I have 2 more minutes? Is that, yeah? So counseling for adult vaccine is the last space, and only about 40% of population who were warranted a vaccine were given a vaccine. So I'll underline that again. So 40% of people were counseled about a vaccine, a far smaller number actually received the vaccine. So even counseling is a space where we have not reached where we should reach. This particular study, which got published in Vaccines in 2020, showed that there was low level of awareness about the general population, but more importantly, much lower level of understanding in the healthcare professional about the benefits of adult vaccination. I won't read through this slide, but it's your recommendation which is important in convincing patients about adult vaccination and the benefits that it accrues. So I have put this under the acronym of SHARE, Counseling for Adult Vaccination. Share the tailored reasons. So S stands for share, the tailored reasons why the recommended vaccine is right for the individual. H is highlight positive experiences with the vaccine. A is addressing patient questions and concerns. R is reminding patients that vaccines protect their loved ones. And E is explaining the potential costs, the economic burden of getting the disease in these individuals. The last 1 minute is about visiting an adult vaccination center. There's various frontline medical staff, nurses and doctors. There should be a vaccination coordinator, and that's all the staff you need. About 2 different people would be your vaccination center vaccinating people. There should be some emergency resources which are important in making sure that vaccination is a safe practice. There's particulars about storage and handling of the vaccine, which are frugal, which are small, but the vaccines need to be stored at the recommended temperature. And there are various guidelines in individual countries, global guidelines, the CDC guidelines, which need to be followed as far as vaccination is concerned. This is a study from my colleague, Dr. Kaul, which I'll finish off with, which looks at emerging vaccines. People who were there yesterday heard about the importance of respiratory syncytial virus as a cause of hospitalization with infections in throughout the globe. This is experience from Kashmir, and he's added vaccines. RSV goes onto the list that we have spoken about a little while ago as important killers, as important causes of severe lower respiratory tract infection in various individuals. I'll stop there as an introduction, and I'll be very happy to take questions. Thank you.
So we've got time. We're getting some questions online. One I've got is, what do you think is the commonest reasons that doctors don't recommend? Is it fatigue? Is it time, barriers, or lack of interest in vaccines?
So I think, Rod, it's a bit of all of the reasons that you said. I think one of the factors is time. I think there is no immediate benefit that doctors feel there is with prescribing a vaccine. I think there's a lot of lack of conviction. We have heard about the non-vaccinators during the COVID era, and there's a lot of doctors who are not convinced about vaccination themselves. So I think that's also another important factor. I think healthcare professionals don't get vaccinated themselves. That's a big challenge. And if you're not vaccinating yourself when you have reasons to do so, I think the chances they'll prescribe vaccine for others is minuscule. So all of those factors, I think, lead to lack of prescription of vaccines.
And one final question, I think. From the floor, did you want to ask a question? No? Okay, sorry, you had a question there. We've got a microphone. That'll have to be the last one. Thank you.
Okay, hi. Thank you for the great presentation. I'm Chanel, I'm from GSK. I wanted to ask you about co-administration of adult vaccines, because I think that's a major challenge. We're quite happy to inject infants with 5 different vaccines at once, but when we get to adults, we don't really want to have more than one, even if there is data to support that. So what are your thoughts on how we address that?
So, Chanel, thank you for that question. I think we have a talk which is on co-administration of vaccines today. However, short answer, I think that's again a mental barrier that the healthcare professional has about administering vaccines together. I think for the wrong reasons, convention has been that you have an interval between having various vaccines, which is not correct. And if you can co-administer vaccine, the chances that the patient ends up getting the various vaccines that they deserve goes up a lot. So a big yes to what you're saying. But I think that's another mental barrier for the healthcare professional that needs to be broken going forwards.